Dr. Oehler. If you don't know me, I'm a pediatric anesthesia fellow here at U of R. And welcome to the grand round today. Um, we'll talk about our presentation. It is called Keep It Clean. It's about infection prevention in the OR and what we can do to reduce transmission from us into our patients. I started this project kind of getting interested during the coronavirus. And I don't know if many of you just thinking, what can I do to prevent getting it myself and myself getting it to other patients as well. So let's go ahead and get started. So, when you talk about infection prevention in the OR, there are 100 different points we can discuss for hours on end. Sulfasalin and antibiotics that we would give to our patients, in which one is possibly the best. We would also discuss things like surgical instruments or anything that could possibly cross-contaminate. We talk about temperature regulation and how that could possibly affect infections in our patients. And then there's patient factors such as, are they clean? Do they wipe themselves down with calcium chlorhexidine gluconate solutions? And does that help? We could also talk about scrubbing, although that's not necessarily entirely anesthesia, as well as traffic in the OR and the OR environment. So when kind of looking at these different elements, I decided to focus on cross-contamination between anesthesia and the patient. This is something that we exclusively have control of, and I think can make a big impact along with obviously the other elements to us. So a brief outline, we'll look at the incidence, the cost, transmission, pitfalls that we commonly have, interventions that we've studied, and possible solutions. And then I'm going to come back to coronavirus and recommendations as a recent update. So first off, we'll talk about the incidence of nosocomial infections. So it is estimated every year that 1.7 million patients are infected with nosocomial infections that are hospital-acquired infections. To me, that's a staggering number, especially because it is a never event. It should, really never happen. And even worse is that almost 100,000 patients actually will die every year from nosocomial infection that they acquire that should never have happened in a hospital. Although we don't have necessarily specific anesthesia numbers, there are surgery-related infections, and these include surgical infections. And unfortunately, these are 22% of nosocomial infections. And that 22%, okay, we're not the biggest section of that, and your Foley catheters are actually the biggest. However, 22% still translates into 374,000 cases per year of OR-related infections. That include OR-acquired infections, central line-associated bloodstream infections, and surgical site infections. So that is quite a big number that we obviously can improve on. Why would we necessarily, obviously we don't want that harm to our patients, but this also relates to going back to payment as far as businesses of hospitals and business of medicine, in that it's more important because lots and lots more of our payment is by bundle payment system. Instead of getting paid to treat, an appendectomy plus a surgical site infection, we are no longer getting paid to treat the surgical site infection. We're just getting paid for the appendectomy. So there are large financial consequences at stake as well. For example, when they started to look at these studies and what we can do in the OR, they actually started first looking at stopcock contamination and how often is it things like this happening. So there was a study actually by Randy Loftus out of the University of Iowa, and they looked just simply at stopcocks to see how often are these incidences occurring from the anesthesia portion of the surgery. And what they did is they cultured stopcocks before going to the OR and then after going to the OR, and they found that contaminations around the stopcock 11%. It's not 100%, which is great. However, there's obviously room for improvement. Considering that there are 49 million surgeries per year, that is still a staggering number of potential contamination, potentially leading to a central line or a blood infection that we accidentally give to our patients. Interestingly, they found in this study that there were factors that increased contamination among anesthesia were the amount of rooms that an attending has. Between the more rooms that the attending has bouncing between, the more incidents that they found of IV stopcock contamination, as well as old people for some reason jump to as well with stopcocks. I don't know why. But the larger the age or the older the patient was, the more likely they were to have stopcock contamination. And then this one made sense to me, and they explained in the paper as well, as ICU. Patients coming from and going back to the ICU had a higher incidence of stopcock contamination. And that makes sense. When you're moving a patient from the ICU bed that they've been laying in for probably days to the OR back to this ICU bed that they've been laying in for days, there's a lot of surfaces that those stopcocks can brush over, go through, and also a lot of hands helping you move that patient. So let's go on to the cost. I'm sorry, I got a little sidetracked. So the cost of all this stuff. Patients with surgical site infections spend roughly 6.5 more days in the hospital, recovering from not only now their surgery, now to their infection. They're 5 times more likely to be readmitted into the hospital after discharge, even after they're quote-unquote recovered from their infection. And if they do contract an infection, they are twice as likely to die during that hospitalization. 60% of them are more likely to require an escalation of care and requiring ICU admission. Again, I don't want my patients to have harm. Obviously, who wants that? But there's also a financial cost. And the financial cost estimated by the CDC is a whole $10 billion per year. Now, if you take that number just for what does that mean to me, say, every citizen every single year pays roughly $30 due to surgical site infections, and carrying in what that cost is to the economy and to society. So let's not pay $30 a year, let's make it zero. So as far as transmission, how does this happen in the OR? What can we do? So this started, as I mentioned earlier, at the end of March and at the beginning of April. I don't know about everybody else, but I kind of went crazy thinking, oh my gosh, how can we stop coronavirus? How can we prevent it in the OR? What happens if I have a coronavirus patient? I don't know. I touch the OR, the anesthesia machine, the entire site is contaminated, and then I give it to the next 5 patients. It was kind of the thought process that started me on this whole journey, this whole presentation. So I kind of started investigating ways to see what I can do, and it's been very interesting. That's why I'm sharing it with you today. So first off, the first kind of early studies that I could find were, again, by Loftus out of the University of Iowa, had an article in 2008 in Anesthesia and Analgesia. In this study, patients were cultured before they were brought to the OR. Anesthesia workspace was cultured before the patient was cleaned. Sorry, was cleaned and then cultured before the patient was brought in to the case. The case went just as any usual case would, and then the patients were then cultured on the way out, as well as the anesthesia workspace was cultured after the patient had left the room. And what they wanted to know was, how do patients affect our workspace environment? Do they contaminate us? And additionally, do we recontaminate patients? And is there a possibility that we would recontaminate other patients by not cleaning our workspace? So the culture showed a contamination of 150 colonies per surface area. And that is not a huge number. It's not, CFUs. However, the general consensus is that anything over 50 over 50 colonies has potential to cause infection. This was thought that, touching, exchange of equipment, anesthesia, as we all know, is very hands-on. So going back and forth between the patient and our anesthesia machine And the anesthesia workspace is a highly contaminated area and highly likely that we're going to be transmitting these infectious pathogens back and forth. Interestingly, they found that transmission of vancomycin-resistant enterococcus to the IV stopcock in these studies, again, this is the early stuff, occurred in 32% of cases, which is a staggering amount. 1/3 of our patients we are getting VRE to. And yes, that came from that patient in the study. However, if your anesthesia machine, your workstation is not cleaned properly, you are potentially giving VRE from your first patient to 32% of all subsequent patients in your room that day. I work in pediatrics. I think tomorrow I have 9 cases. I hope that first patient is not VRE positive, because there's a potential I can give 3 of those other children potential pathogen. So I think this is interesting. They also found that skin contaminants were also a major component of transmission, as well as MRSA, as far as being transferred to the patient. Moving on, so let's just take a minute here and think what do you think are the most, what do you think are the areas most contaminated with germs? Think about what we do every day in the workstation, and see if you can group chat your responses. We'll try and make this as interactive as possible. And see. I'll give you a couple minutes because I know most of you are on mute. Great. I have gas knobs, ventilator buttons, the APL, Texas machine, keyboards, the cart handles, okay, my popcorn we fizzled out, so. Room phone, that's good. Head of the patient bed. The bag or the reservoir bag. Okay, cool. All great answers. Ew, I second the room phone. Okay, let's go back to this and slideshow. And okay, so those are all great answers, and we are all hitting pretty much the nail on the head. So we're all aware and guilty. There was a study, and this one was from New Hampshire, out of Dartmouth University, and they looked at the areas most commonly contaminated with patient germs. And the first one was the towel on the anesthesia machine. For me, that makes sense. I know not everybody uses a towel, but I do because I feel like it's cleaner. But it makes sense because, usually when you intubate a patient, where you put that dirty blade, I put it right on that towel because that towel was clean, and that keeps everything else from getting clean. So that makes sense. Reservoir bag was something that we had, obviously because you're touching the patient, and then you go right to that reservoir bag to ventilate, going back to intubate, and then you go right back to touching that bag. So thank God that's removable. The reservoir bag was the second. Suction tubing was the third. In the study they did not mention it was changed, but I imagine it was changed, as everybody does. But that makes sense because usually we use that quite often, and it's always touched either to remove it from patient's face after intubation, or we obviously use it to suction something. The oxygen flow valve, again, very logical. Because and the APL valve, because those are the things we touch between intubating and ventilating, going back to adjust your flows, adjust everything, and going back. Something that is a kind of a dull moment was number 6 for me. Your stethoscope. We listen and put that right back over our necks without cleaning it or doing anything else. So that was not surprising. The IV hub, because makes sense again because we're ventilating the patient, putting medications in, putting that back, and then ventilating the patient again. The vaporizer gauge, because who doesn't turn on some single flow and you turn it down with pediatrics. The keyboard, which we all thought of, and the scariest one for me was the box of gloves. It makes sense because not everybody washes their hands afterwards and goes right to change their gloves. So the box of gloves for me was kind of scary that we think we're going to put something clean on it, and unfortunately it is actually contaminated. So those are the areas most commonly contaminated in our anesthesia workstation. So let's go through some more. We'll just touch on a couple of them. The biggest ones are intubation, stopcock use, and hygiene, extubation, as well as cross-contamination. So first off is intubation. When they were looking at studies, this one was out of University of Miami by, his name, Bierenbach was his name. He looked at intubation and what are the most common times that we are potentially cross-contaminated. Intubation and extubation were the two biggest ones. So he focused specifically on intubation to see what are we doing, what can be improved. And their theory was that double gloving would potentially reduce the amount of contaminations between the patient and the rest of the room. So he took 40 residents, because residents make fantastic studies, and guinea pigs. And he had the residents through a simulation. He had them intubate in 6 minutes, and they used a mannequin that had fluorescent dye in their mouth. He took these 40 residents, half of them had single gloves and washed their hands and put new gloves on. The other 20 had double gloves and had a reminder to, as soon as they intubated the patient, to remove those gloves. And intubation of the patient meant as soon as the tube was in and the balloon was inflated, they took the gloves off before going back to the anesthesia machine, going back to the reservoir bag to make sure the patient is ventilated and the tube is in the right spot. So that's a key component, to take your gloves off as soon as you touch the patient, or are done touching the patient with intubation. And what he found was that there was 4 times more contamination around the anesthesia workstation with single glove participants. And that not only was it all over the workstation, it actually traveled out to the OR door handle. They found a fluorescent dye. So, our actions, although they seem, that it may be only affecting us, it affects everybody in the room. It affects nurses or anybody else touching that door handle in the OR. And in his study, he found, not necessarily contrary, but in concordance, that among the patients, even with double glove and with single gloving, that the most common contaminated patients, or where they found the most fluorescent dye, was at the APL valve and the oxygen dial, were his two most common. So consistent with the others, not exactly lining up, but consistent with the other studies. The next is stopcock contamination. So in 2008, Loftus and the University of Iowa was looking at stopcock contamination, as it was thought that propofol was the biggest risk factor on the stopcocks. As we all know, propofol is lipid nutrient rich, and it just loves to grow any kind of bacteria that we have. Staphylococcus, Streptococcus, Corynebacterium loves to grow in it. So much so that the manufacturer has added EDTA, and even after they added EDTA to stop bacterial growth and obviously preservative as well, that they still recommend discarding any open syringes or any open vials of propofol after just 6 hours. The manufacturer also recommends discarding tubing every 12 hours because they don't want to be responsible for contaminating any patients with growth in their propofol. However, a study by Robert, they were looking at it. Is it the stopcock, or is it actually the propofol that is causing infections in patients? So they actually took 302 infusions for which patients received propofol through the stopcock, and they saved the propofol vials and inside the propofol they cultured as well. And they found that of those 302 patients, 18 were actually positive for growth culture for growth on culture in the propofol itself. So they cultured that propofol, and they also cultured patients. Interestingly, there was no concordance between the patient culture and what they were growing and the propofol vial and the propofol bottle, which kind of which was surprising to the people studying it. They thought that there would be almost 100% concordance, in that if it grows in the propofol, we're giving it to the patients through the propofol. And because of the disconcordance, they actually thought the thought process went to that it was actually stopcock contamination, which was growing in the patients, and not necessarily the propofol itself. So a little bit of a history on that. The IV catheter. So they further went looking. This was Loftus back in the University of Iowa. Went looking at contamination from the anesthesia machine to the IV stopcocks, because as we know, we're back and forth quite often. And what they found was that contamination, the highly contaminated areas, aka the anesthesia machine or the little shelf that we have, had the worst pathogenesis. Meaning that that's where we had all of our BREs, all of our MRSA. And they looked at what can we do to reduce the amount of bacterial contaminants or viral contaminants given to these patients. So they looked at using, instead of having the open tip stopcocks, they looked at having a hub, in which is not necessarily an open tip, but a hub that you can something scrub. For most of our IVs here, RV tubing here, you can see that's the little blue thing that we can scrub very easily with alcohol, as opposed to the three-way stopcocks. And that's a suggested use of a passive catheter care system in an effort to reduce the IV contamination. And at University of Rochester, I'm glad to see that we actually have the alcohol caps to put on there to keep those IV hubs clean. I think it's a great thing to reduce infection that we give to our patients, and I'm glad to see that it is a recommendation and requirement on the website. Let's transition a little bit. I think we beat catheters to a dead horse at this point, and I will bring up Ignaz Semmelweis. So he was not an anesthesiologist. Unfortunately, he was an obstetrician. However, he's interesting because obviously they named him in a study, and I kind of looked into who he was. I remember the name, but from medical school, but not very well. So he was an obstetrician. He was working in Austria in the middle of the 1800s, and in Vienna, they had two places where women were giving birth. They had the doctor's hospital, in which it was MDs training medical students and residents, and then they had the midwifery hospital. And in the midwifery hospital, the incidence of puerperal fever was much lower. At the time, that was. Now we know that that's postpartum infections or anything like that. At the time, they didn't know if it was an infection. They didn't understand biology, bacteria, or if it was a virus. So they just called it puerperal fever, which is fun to say. So he looked when he was the medical director of this hospital and thought, we could do better. What are we doing differently in the doctor's hospital that they're not doing at the midwife's hospital? And he looked and thought, well, if we're examining cadavers that are dead and not washing their hands before going to see patients, maybe we are carrying something from the dead patients and the cadavers to our live patients, causing our larger rates of the fever of infection. So he started actually washing his hands and encouraging all his medical students to wash his hands, and everybody to wash their hands not between patients, but actually between examining the cadavers and examining your patients. And within 2 years of starting to do this, he actually was starting to beat the midwife hospital as far as their puerperal fever rates. He did not know what the vector was. He didn't know if it was. He had no idea why it was working, but he knew that it was working and thought that it should be kind of commonly accepted to do things like this throughout the medical community. So he spent pretty much the rest of his life trying to advocate for washing their hands between examining cadavers and examining patients. Unfortunately, he was poo-pooed. The medical community at the time thought that he was nuts. They thought that washing your hands was ungentlemanly because they were gentlemen and they thought that there was no way that they were getting their patients infections or transmitting anything. So it's interesting to think that the medical community can shun, and it kind of points out the shock in the culture of what just the culture and what is our everyday norm and change how that affects our patients. So okay, we got off track. Let's get back onto it. So in citing his name, there was a study. This one was out of the University of Miami as well. And it was observation of anesthesiologists pointing to hand hygiene as defined by the WHO, which if anybody has been around U of R, I'm sure you've seen those things on the computers coming back saying when we should be washing our hands. So they had observers of anesthesiologists, and they pointed out every time that we should be washing our hands during patient care. On average, we should be washing our hands 34 to 41 times an hour. I'm going to drink to let that sink in for a minute. And at peak times of activity, we should be washing our hands 54 times per hour. Obviously, that's difficult to do. Obviously, our compliance was 18% or failure rate of 82% if you want to look at it. So we're more failing than we are succeeding. And just the sheer amount of time. If I was to wash my hands or alcohol my hands in the OR 54 times per hour, I think it would be very, very difficult. So we were they're looking at ways in which we can improve hand washing compliance, and is a culture thing in which we should all just ingrain ourselves, train ourselves more, or are there other alternatives, which unfortunately, I'm sorry for the choppiness, but we'll get into in a minute. And just as a refresher, because we are not all sick of it, the hand washing recommendations from the WHO are here. Wash with soap and water when visibly dirty or contaminated. Fantastic, not just from after observing cadavers. Using alcohol base for routine antisepsis. And then performing hand hygiene. So if you look at this is where anesthesia really comes in. Before and after contact with patients, after removing gloves, before handling invasive device, after contact with body fluids, when we're moving from contaminated site to a clean site, after contact with inanimate objects in the immediate vicinity of the patient, aka the entire anesthesia workspace, and before handling medications. So this is why we are highly hand washing dependent in anesthesia, and why I think it's very important for us to have it, and to have alcohol readily available in a site that is convenient and easy for us to get to during patient care. And based on this, it's very easy to see why we have such high rates of contamination going from us to the machine, from the machine to our patients, just because we are so hands-on and we work very fast. Alcohol in hands. So in late March and early April, I was washing my hands, or alcohol in my hands, like crazy. I'm sure many of us also in Rochester get very, very dry hands and cracked hands and irritated hands just from the dryness and washing our hands so constantly. So I feel your pain. And the people in Miami, this was another study from Bernbach, and they looked at alcohol in hands from an anesthesiology perspective and washing your hands. What is the consequences of that to our skin? So they had volunteers, aka medical students, who studied use of the alcohol on your hands for every 15 minutes, 8 hours a day, over the course of 5 days. So they had a dermatologist look at these patients before, and they rated them on a hand eczema severity index. Before going in, the medical students averaged about 1% on their dryness and irritation of their skin. And then after just 5 days of doing it every 15 minutes, they had an increase of the severity index went from 1% to 6% just in the 5 days. So everybody feels our pain of washing your hands and putting alcohol on your hands all the time. Interestingly enough, they found no difference between Purell or Purell Plus, the moisturizer, as far as irritating your skin. So, but we can, we have to suck it up and suffer. However, what I've been doing, and I'll touch on it a little bit later, is starting to keeping some gloves on and alcohol in the gloves, because you can alcohol gloves easily every couple of minutes or every minute almost, without any damage to your skin. Because as much as I love my patients, I don't want to make myself sick by having cracks in my hands, which I can get infected from, and then give that to my patients as well. That is a dead horse. So the next pitfall that we have is extubation. Extubation, if you think about it, is not necessarily a difficult time to cross-contaminate. It's a very busy time. I am ready to get out of the OR at that point as well. But what they observed is that during extubation, poor compliance in changing gloves after removing the ET tube was the biggest factor. People take it out, throw it in the garbage, and then just continue. And aerosolization of saliva is also, it's also a no-brainer why we are exposing patients and our anesthesia workstation to more contamination risk. And there's the best ways to improve it. Instead of, taking the ET tube out and flinging it around the room and looking for the garbage, they looked at, possibly putting the towel on, or they suggested possibly putting a towel on the patient's chest, in which you can put it in, and then bedside nurse can take that towel and ET tube, and put it in the garbage from there. They also looked at, or suggested, putting the ET tube directly into the garbage after it's moved. And when I was looking at this, the results of the study findings and suggestions, it became much more apparent to me of, how many bedside nurses kind of give that ooh look, and they kind of turn their head away. I don't know if it's because they're disgusted with saliva or because they've been left in the face so many times by ET tube or phlegm coming out. So that's something I keep in mind and like to joke about every day. However, it is serious. That's a big pitfall when we are trying not to contaminate our area. And then if anybody's worked in, I think it was March and April with Dr. Carell, she had a plastic barrier, which I think they were working on at University of New Hampshire, or I'm sorry, Dartmouth in New Hampshire, as a possible way to reduce the OR contamination, environmental contamination from intubating and extubating patients. And there's a picture of it there on the left. And you can see it's just a clear plastic barrier that you can stick your hands to, kind of like an incubator. So what that does is that, it protects us, it protects the anesthesia workstation, and not so much in the front. But it ideally will catch any of the aerosolization of the saliva or anything that the patient is potentially coughing out. And this was a reaction to coronavirus in ways to reduce the transmission. And then, so in that study, they also looked at, cross-contamination. What can we do to redesign our workstations? One of it, and this has been going on even before coronavirus, is the use of a clean hand space. I know when we were looking at what are the dirty spaces, I saw anesthesia cart handles, I think from Dr. Weber, and then also possibly the Pixis. And what they have suggested is to have a clean area, and this is actually from a SPA website where the patient or the doctor is demonstrating clean and dirty areas. The clean area should have nothing that has ever come in contact or near contact vicinity within the vicinity of the patient, meaning all your medications should stay back there, anything for possibly your next patient should stay back there. Anytime you go to that area, you should alcohol your hands or wash your hands, and that is essentially your clean area. Nothing goes between the clean and the dirty. I'm sorry, nothing goes from the dirty to the clean. Everything goes from the clean area to the dirty area. And as you can see, she obviously has a bare hand on the clean side, and she uses a glove on the dirty side, and that everything in the dirty area should be touched only with gloves. And that is one aspect that they've looked at as far as, or suggested as far as reducing the intraoperative cross-contamination between patients and the anesthesia workstation. Furthermore, what can we do? I started looking at other ways that we can reduce this contamination. And there are a couple of suggestions and studies of what can we do to change the design of our machines to make them easier to clean. Our draggers have a lot of knobs. I like using them, but there's a lot of knobs, there's a lot of crevices that bacteria and viruses can come into. They suggested possibly changing that in the future. I don't know if anybody's ever looked at a GE machine before, but there's a lot less knobs. Dialing in your gas is just done by all one knob. And designing those machines make it easier to clean, reducing contamination, reducing bioburden on the anesthesia work area, as possibly a suggestion. Another study that came, this was out of the University of Miami, I think I referenced it earlier with Dr. Burnback, is alcohol in your gloves. And I thought that this was interesting because I've heard it, I've never tested it before this. But alcohol in your gloves constantly throughout the day would pretty much break down the nitrile gloves and reduce their efficacy as far as preventing contamination to us. So they looked at this myth to see, is it true? Does it do anything? Is it easier to reduce the amount of alcohol we put on our skin, including this eczema and all the other irritants, by just putting alcohol on the gloves? So what they did is they took study subjects, aka medical students again, and they had the patients they had medical students wear gloves for 8 hours. They had to take a picture of them alcoholing their nitrile gloves every 15 minutes to send it in to assure compliance, and they wore the same gloves. They took those gloves afterwards and compared them to the integrity of them to gloves that were fresh out of the box. They measure the integrity actually by how long they can hold water without leaking, to see, do these things start to break down? Is there anything that goes on? And what they found, interestingly, is that there was no difference in the integrity of the glove. The gloves perform the same way. They function just as well as far as holding water for just as long, kind of breaking down that myth of the alcohol kind of eating away at your gloves. They also further went into that study to see, do the gloves get sticky? So they used tactile, they wanted to measure the tactile responsiveness. So they actually had the medical students pick up quarters off of the table and how long it took them to do that with gloves on in the beginning, and at the end of the day to see, do we lose that tactile feeling from the gloves and if there is any breakdown. And they found no difference. They didn't find that there was any gumminess on the gloves during the study as well. So they recommended that as a possible solution. It's kind of a follow-up study to our earlier alcohol on our hands. As a possible solution, and myself, I've been using it for a couple of weeks now. And again, I'm still changing gloves and alcohol in my hands, just alcohol in my hands less by alcohol in the gloves, and I don't notice that much of a difference as far as what do the gloves feel like. And I think that this is a really good and easy way that we can reduce A, harm to ourselves, and B, harm to our patients. I'm sorry, A, harm to our patients, and B, harm to ourselves, just by putting alcohol in your gloves instead of your hands. So I suggest you to try it. Another thing that we can do to reduce transmission is an anesthesia machine cover. This is interesting. I kind of dove into it, and this is a picture of it here. Oh, sorry. And as you can see, all it is it's from Bell Medical. It is called the anesthesia hygiene cover, and it's just a big piece of plastic that goes over the anesthesia machine and over the anesthesia workspace. The idea is that you can take this away at the end of the case and reduce all the contaminants. You can customize this in that, as you can see on the right-hand side, the bronchoscope or the fiber optic goes into this nice little beautiful pouch that seems really kind of nice in there, so it's not flopping all over and taking, something we put down a patient's airway and letting it flop all over freely in the OR. There's also a garbage bag that you can see on the bottom, and some of these you can customize. You can customize them to the machine. You can customize them to exactly what they cover if you want it just to be the bottom surface of that machine or the work surface. or if you want the monitors covered. And then you can also customize it to having pouches on the side of that in which you can put your laryngoscope, um, and you can actually tear that portion off and wrap the laryngoscope so it's completely covered and not aerosolizing any contaminants throughout the case and easy to dispose of. I think it's a great idea. However, looking into it, they clearly state that each cover, depending on how you customize it, is going to cost between $30 to $50. So it is, yes, it's great at, for our patients. However, is it really cost effective? Can we just wipe down our machines? And also the environmental impacts. Again, tomorrow I have, I think, 9 cases, and I can't imagine going through all that plastic. That's a lot of plastic in the OR, covering the anesthesia machine. So you have to also consider the environmental impacts. However, perhaps this would be great for patients that we know have, VRE or MRSA, or even our coronavirus patients. I think maybe if we would reduce it not to every single patient, but to, known pathogenic patients, I think this would be a great idea. And this kind of leads to the part of the coronavirus. So again, I talked about this really made me nervous in the beginning of, end of March, beginning of April. So I started looking at it and, how is this vector transmitted? We're used to seeing aerosolized contaminants. We're used to seeing, contaminants that live on surfaces for a long time. But I think coronavirus kind of frustrated me because it's respiratory aerosolized, but also it lives on surfaces. And what we're finding, what the data is showing now, is that it can actually live on surfaces for 3 days, which is an extremely long time to live on surface, and it gives it a high contagion factor in that, someone with coronavirus came by tough on a door handle 3 days ago, and now you get it today and start transmitting it. And what they're also finding is that it's transmitted from fecal shedding, which is, I just like the word fecal shedding, so why not put it in there? But what they are finding that is interesting and I like is that when they are sampling patients, or when they're sampling providers, as you can see, the guy on the left has the full PPE on, the goggles and everything, that when after doffing, they sample the PPEs, and they're actually mostly negative from coronavirus. Again, this is due to the patient characteristics, how much viral load they have, if it's shedding. But I think that's something encouraging, and it was encouraging for me when I found out that they're mostly negative. It's not you walk in with PPE and your protective gear is automatically contaminated, and how are we going to stop it from surviving on my skin for up to 3 days afterwards? And then they also are looking at after you clean routinely patient areas, that after just routine decontamination measures, it is actually, they can't find any detection of it. So it is easily killed as long as we go by our thorough decontamination, routine, regular cleaning, and do a good job of it. So that's encouraging news. I was actually kind of glad to find out about this. And throughout my couple weeks of research on this and looking into it, last week was interesting because in Anesthesia and Analgesia, coming out next month in print in July, but out now online, is the ASPF task force. So the Anesthesia Society, Anesthesia Patient Safety Foundation, actually has an article this month that's fascinating. It's very succinct. I highly recommend everybody read it. But they kind of highlighted pretty much what I've been spending the past couple months looking at. 4 steps to reduce transmission of coronavirus in the OR. Their suggestions are to double glove for intubation. They are also suggesting alcohol on the IV pole on the left-hand side to make it easier for us to alcohol our hands during patient contact. They're also suggesting environmental cleaning. I thought this was really interesting. They are suggesting for us to designate a clean and a dirty area, and the dirty area specifically being a plastic bag on the right IV pole with a mesh wire basket in which you put dirty gloves as well as the laryngoscope immediately after use, and have it as almost a Ziploc seal, which I think is really a good practice to get into. I've been practicing, kind of putting it in my glove haphazardly, and then when I have time to clean my hands, put more gloves on. I've been taking those 30 laryngoscope plates and putting them in the biohazard bags. Again, because I don't want coronavirus to be transmitted to the OR, transmitted to the OR environment, infecting the nurses, any patients, anybody else. They're also suggesting to wipe down equipment surfaces immediately after induction. So, induce, intubate, get the patient squared away, and then start wiping everything down, because as you can see that in the OR, the APL valve, the reservoir bag, the dials are the most contaminated areas that we have in the OR. So I think it's very worthwhile to wipe those down. And then routine terminal cleaning, they want us to improve the way that we do it, or a way to improve it is to start from the top down. The idea is that as you're cleaning through everything, you are taking the coronavirus or the COVID virus and aerosolizing it, and that will fall with gravity. So they want us to start at the top, wipe everything clean from there. Hopefully the virus will fall lower, and then we can clean that up later. This is a suggestion, and then also to use UVC light, because that reduces the bioburden of coronavirus on our surfaces. Another thing they want us suggest is patient decolonization. Obviously, PPE for anesthesia providers, so that even if they are colonized, they're not giving it to us, and then by reducing our colonization if we were to get it. But what they are suggesting, and I think it's standard practice, I know at least at Children's, is to have pre-procedure chlorhexidine wipes for the patients. The little kids come in, we completely wipe them down. I think it's great. And if the patient is under suspicion or a known coronavirus patient, they want nasal povidone iodine within 1 hour of the incision. They want us to swab in there for a minute twice, as well as doing a chlorhexidine mouth rinse either before going into the OR or after induction. They suggested that even if it is a emergent case, obviously take care of the patient and then wipe the patient down with the chlorhexidine, do the iodine nasal swabs, and then mouth rinse afterwards to reduce the amount of viral shedding, A, in the OR, and then B, when transporting the patient. So I think those are very interesting recommendations from task force. And then obviously vascular care, which we went through earlier, having a closed IV system, always having hubcaps on, scrubbing the ports, and then keeping your medications capped to reduce the amount of contamination that can go on our vials. So that is the kind of great, interesting. I'm glad that they have kind of boiled my presentation down for me, and that we're all kind of on the same track. The ASPF also has a step 5, which is surveillance. It's kind of out of scope, but they are looking at all steps. Obviously, the recommendations that they've given are behavioral, and obviously they have variable compliance. They're obviously prone to fail, and they need data feedback. So what they are suggesting is that hospitals and us use the ESCAPE, which is bugs, which is Enterococcus, Staph aureus, A is Acinetobacter, Pseudomonas, and Enterobacter as a fidelity marker to see how those are transmitted, as well as coronavirus. And monitoring, are these 4 steps working? Are they reducing contamination in the OR? So that is it for me. I open the floor or the discussion to any questions that anybody has. Comments.